Autism, a word that carries complexity, stigma, mystery, and for many, a deep sense of identity. Autism spectrum disorder, or ASD, is one of the most talked about neurodevelopmental conditions in the world today. But within all that talk, one question keeps coming up. Where does psychiatry fit into the autism conversation? Is autism a mental illness? Should psychiatrists treat it? What role do we play in diagnosis, support, or intervention? This video is an honest, thoughtful exploration of psychiatry's relationship to autism, past, present, and future. Whether you're a parent, clinician, autistic adult, or curious listener, this is for you. Let's begin. What is autism spectrum disorder? Let's start with the basics, not to oversimplify, but to ground the conversation. Autism spectrum disorder, ASD, is a neurodevelopmental condition characterized by persistent difficulties in social communication and interaction, restricted and repetitive patterns of behavior, interests, or activities, symptoms that begin in early development and affect daily functioning. But within that spectrum lies incredible diversity: nonverbal children and highly verbal adults, sensory seeking and sensory avoiding behaviors, people needing round the clock support and others thriving independently. Autism is not one thing, it is many things, shaped by biology, environment, experience, and culture. Psychiatry and autism, a complicated history. Let's be honest, psychiatry has a fraught history with autism. There was a time, not long ago, when autism was misdiagnosed as childhood schizophrenia. Parents, especially mothers, were blamed for causing it. The refrigerator mother theory, treatment focused on suppression, not understanding. These were harmful narratives rooted in ignorance and stigma. Thankfully, we've come a long way. Today, psychiatry recognizes autism as a neurodevelopmental difference, not a psychosis, not a behavioral failure, and not a choice. But old wounds take time to heal, and that's why listening to autistic voices, not just medical ones, is so important today. So, is autism a mental illness? Here's where the language gets tricky. In the DSM-5, autism is categorized as a neurodevelopmental disorder, alongside ADHD, intellectual disability, and others. But that doesn't mean autism is a mental illness in the traditional sense. Mental illnesses like depression, bipolar disorder, or schizophrenia often begin later in life, fluctuate over time, may resolve with treatment. Autism, in contrast, starts in early childhood, is lifelong, is not something to be cured. So, no, autism is not a mental illness. But yes, psychiatrists still have a role to play. Let's talk about what that role looks like, where psychiatry fits in. Core roles. 1. Diagnostic support. Psychiatrists, especially child and adolescent psychiatrists, often participate in multidisciplinary evaluations. This can involve developmental history, observation of behavior, screening tools like the ADOS or ADIR, ruling out other conditions, e.g., social anxiety, language disorders. Diagnosis is often collaborative, involving pediatricians, psychologists, speech therapists, and educators. But psychiatrists offer a unique lens, one that integrates behavior, development, mood, trauma, and medication history. We help ask, is this autism, is it something else, or is it both? 2. Identifying co-occurring conditions. Over 70% of autistic individuals have at least one co-occurring psychiatric condition. Common ones include ADHD, very common, anxiety disorders, depression, obsessive-compulsive disorder, sleep disorders, bipolar disorder in some cases, catatonia, rare but serious, psychotic disorders, controversial and complex. Sometimes these conditions are masked by autism traits. Other times, autism itself is masked by mood or behavior issues. Psychiatrists are trained to see the layers, and that can lead to more accurate diagnoses and better care. 3. Medication management. Let's be clear, there is no medication that treats autism itself, but medications can be helpful for certain symptoms or co-occurring conditions. Examples include stimulants for ADHD, SSRIs for anxiety or depression, though caution is needed, antipsychotics, e.g., risperidone, aripiprazole for irritability or aggression, melatonin for sleep issues, mood stabilizers in select cases. Medication decisions must be personalized and should always be used in combination with behavioral, educational, or therapeutic support. Psychiatrists also monitor side effects, especially in nonverbal or sensory sensitive individuals. 4. Therapeutic support. Some psychiatrists also offer therapy or work closely with therapists. This may include psychoeducation for families, parent coaching CBT, adapted for autism, social skills training, coping strategies for emotional regulation. Therapy is most effective when it's respectful, individualized, strength based, focused on support, not normalization. 5. Advocacy and systems navigation. Many psychiatrists help families access special education services, advocate for accommodations at school or work, apply for disability support, coordinate with primary care therapists and schools. Autism care is a team sport, and psychiatry can be one important player, listening to the autistic community. A vital shift is happening, and psychiatry must be part of it. More and more autistic people are speaking out, and their message is clear. We don't want to be fixed, we want to be understood. Autism is a neurological difference, not a defect, and many autistic adults reject pathologizing language. They prefer terms like autistic person, identity first language, neurodivergent, support needs rather than low functioning. Psychiatry must evolve by listening, respecting self advocacy, avoiding ableist assumptions, focusing on well being, not normalcy. This isn't just about science, it's about humanity. Challenges in psychiatry's role. Let's also be honest about the challenges we face. 1. Misdiagnosis. Some autistic people, especially girls, women, and people of color, are misdiagnosed with borderline personality disorder, social anxiety, schizophrenia, bipolar disorder. Others are missed entirely, especially those who mask their traits. We must be more aware and less biased. 2. Overmedication. Some autistic individuals, especially children, are prescribed too many medications, often without adequate behavioral support. This can lead to sedation, weight gain, emotional blunting. Medications must always be used judiciously, not as a substitute for understanding. 3. Trauma. Misinterpretation. Many autistic people experience trauma, from bullying, medical mistreatment, sensory overload, or social rejection, but their trauma responses may be misread as meltdowns, oppositional behavior, psychosis. We must learn to recognize trauma in neurodivergent presentations and treat it with compassion, moving toward neurodiversity affirming psychiatry. The future of psychiatry must include cultural humility, neurodiversity education, autistic informed care models, collaboration with autistic adults. Let's stop asking, how do we make autistic people act neurotypical? And start asking, how do we help them thrive as they are? Psychiatry isn't about fixing people, it's about reducing suffering and enhancing lives. That's true for everyone, including the neurodivergent. Final thoughts. Autism is not a disease, it's not a tragedy. It's a way of being in the world, one that deserves understanding, support, and dignity. Psychiatry has a role not to diagnose and disappear, not to medicate and move on, but to partner with individuals and families on the journey toward mental well being. Where do we fit in? We fit in when we listen. We fit in when we respect. We fit in when we stop trying to fix and start trying to understand. Let that be our new model of care. If this video helped you better understand the relationship between autism and psychiatry, please like, share, and subscribe. Drop a comment. What do you wish more psychiatrists understood about autism? Until next time, take care of your mind. And remember, different doesn't mean broken, it means human.